over Europe in people interested in gender in medicine.
Many chronic diseases differ significantly in women and men in risk factors, prevention, clinical manifestation, response to therapies and outcomes. There is a need to improve the understanding of sex and gender differences regarding treatment and prevention activities in European countries.
Gender mainstreaming is a long-established EU principle to be taken in account in all policy areas. And in the field of health, the third program of health, 2014-2020, explicitly invites member states the mainstreaming the gender in all actions to support by this program. For that, the Commission is supporting member states. All the practices that we will listen this afternoon here in this conference are really welcome.
There is a need to promote women and girls in order to achieve that equal access to resources, etc. And we will see it, I'm sure that it's being discussed in the Gender Equality Index, although we are in the region of the world that has achieved the highest levels of gender inequality, there is not one single country that is there. So the systematic use of gender across our work in health means that we are addressing the needs of men and women from a gender approach.
Should we be thinking about having different approaches to looking at men? I'm doing an evaluation of a perpetrator program for men who have been violent within the household, and what comes out is how damaged these men are. And if they've been picked up earlier and managed better, we perhaps would have had them not damaging other people. We also have issues around men's weight. More men are overweight, but nearly all the services are focused on some women's weight. And we need to be thinking about, with the visceral fat that men have, how do we get them engaged in weight loss groups? And we now have evidence across many different sectors.
At the Medical University we also have a triple track, very important, because we have education, research and patient care. And I think the end must be the patient.
Most of the recommendations we have on hypertension in pregnancy is still expert opinion, and I think this should be changed. We desperately need good studies in pregnancy.
What's my experience right now from the projects and from other proposals as well, because it's easy from a researcher to write something about gender or sex or just mention it in a proposal that you have mentioned it, but doing it really in your research, I think it's a total different story.
Most of the colleagues, they are in the knowledge of this evidence which is existing, but still somehow this is ignored. And we need to find a way to deal with this knowledge and bring it to the clinics, because it's not existing. Maybe it's not even in the guidelines somehow.
What can be your contribution? Disseminate gender-specific knowledge. GenCAD partners develop fact sheets for healthcare professionals and the general public on gender differences in coronary artery disease. The fact sheets include evidence-based facts like new risk factors, mechanisms of diseases, gender and prevention, gender and clinical manifestation, diagnosis, management and outcome.
We have been really great with developing fact sheets and improving the data. We now have the evidence why gender is important, but we now need to take more attention to how do we get that evidence into practice. We need to talk about management and leadership and governance. Second, we have started with gender and medicine, especially cardiology. But the healthcare system is much broader, and it's time to think of all the other health professions, of the managers, of the nurses, the physiotherapists, and so on and so on. And the healthcare system is changing. We need to think about how to improve gender sensitivity in teamwork and these kind of things. And this needs new programs, new funding, new and a continuity of these networks to bring that to the second steps.
You can download the fact sheets available in 24 languages by following the links in the video description.